All right. Good morning. Welcome to In the Trenches with DAC. Today's topic is vasculitis. I'm going to just go over an approach to vasculitis. Let's determine what it is. A vasculitis is inflammation of blood vessels, the blood vessels gets inflamed and you get subsequent ischemia to organs. Now, actually, when the blood vessel is attacked, you could get two things. Either the vessel narrows, when you get ischemia, or it dilates, and you get an aneurysm formation. And you can see both with vasculitis, but classically you think of the vessels narrowing. So when you say somebody has vasculitis, it has to be a syndrome. It has to be an entity. You just can't say vasculitis. So this mnemonic, when you're considering vasculitis, you have to think of this. The mnemonic SPIM. S is subacute. So vasculitis is usually gradual. It comes on gradually. It doesn't come on wham bang. The exception is giant cell arteritis, temporal arteritis. These patients often can recognize the second symptom started, but beyond that, it's subacute. Number two, it's painful. Vasculitis hurts. These patients are in pain. They're all degrees of pain in different sites, but it's a painful entity. Number three, there's signs of inflammation. Fever, arthralgia, myalgia, signs of inflammation. And number four, it is multi-system. Okay, so it involves multi-system, it involves multiple systems. Think of that when you're thinking about vasculitis. So the next thing, you want to classify vasculitides. So basically, you have large vessel, medium-sized vessel, small vessel, and very small vessel. So the large vessel vasculitides involve the aorta, all right, or its branches. Okay, with this you think of giant cell arteritis and Takayasu's arteritis. Now there's some other things you could think of also, IgG4 related disease, Duchenne syndrome. So there are other cases of large vessel vasculitides. Most common is giant cell arteritis. Okay, the medium size, classic, you think of Polyarteritis nodosa is the classic entity that you think of here. Also Kawasaki's, which you see in children. Medium-sized vessels involve named blood vessels. Okay, small vessel vasculitides, you think of the ANCA-related vasculitides, GPA, MPA, eosinophilic granulomatosis with polyangiitis. And these could also involve medium-sized vessels. Okay, and then the very small blood vessels, you think of the leukocytoclastic vasculitides. And we'll talk about these, predominantly involving the skin, maybe the glomeruli. Let's talk about these all a little bit. We're going to start here and work our way back. So the hallmark of a leukocytoclastic vasculitis is a palpable purpura. That's the hallmark. So if you see a patient, and this would obviously be better with visuals, okay, if you see a patient and they have a purpuric lesion and it does not blanch and it's palpable, you think of palpable purpura, leukocytoclastic vasculitis. Now, it could clearly be idiopathic, okay, but the things you think of, cryoglobulinemia, especially due to Hep C, could do this. Connective tissue diseases like lupus, rheumatoid arthritis, Sjogren's have been reported. have been reported to do this. Sometimes you could see this with the ANCA diseases. They often are more nodule. Henoch-Schönlein purpura has been reported to do it. Certain drugs have been reported, and they've reported this with other conditions. But the things you have to think of are connective tissue diseases, having a small vessel vascular disease like lupus, medications, cryoglobulinemia, which is not the most common thing in the world, but you can see it, medications, and also Henoch-Schönlein purpura, which you can see in adults. What else do you see? You can see glomerular involvement. Okay, they could actually have RPGN, they could have nephritic syndrome, red cell casts in the urine, red blood cells in the urine, proteinuria. But it's often the skin. Henoch-Schönlein could involve the GI tract. Okay, cryoglobulinemia could also cause a neuropathy. Connective tissue diseases could have an array of findings. The thing you need to realize with this, it's a palpable purpura. And then you would go on and try and ascertain the cause of the disease, getting complement levels, immune markers, etc. The ANCA-related vasculitides, okay, these usually could cause pulmonary renal syndromes. GPA has a positive C ANCA usually. It involves the upper airways, the lungs, and the glomeruli. You could really see anything on chest imaging. The one thing that you rarely see is mediastinal lymphadenopathy. MPA is like GPA, except it doesn't involve the upper airways. It causes a pulmonary renal syndrome and a pulmonary vasculitis, but you don't get granulomas formed, so you don't see the nodules. You don't get granulomas. Slightly better prognosis, more associated with the PANCA. EGPA used to be called Church-Strauss. This is about 50% of the time they have positive ANCAs. You think of somebody who has asthma who's not getting better, asthma and eosinophilia, and possibly evidence of vasculitis. And this could involve the heart, it can involve the peripheral nervous system and other organs. Doesn't as commonly involve the kidneys. These are the ANCA-related vasculitis. Now, the medium-sized vasculitis, polyarteritis nodosa is what you think of, and it involves branches of the aorta. Involves the celiac artery, superior mesenteric artery, renal artery. It could involve the kidneys, but not the glomeruli. You would diagnose this with a renal arteriogram. There used to be a very strong association with hepatitis B. It used to be like 20% of the cases. I think that went down since more hepatitis B is being treated. The other thing you could see with this, and you could also see it with the smaller vessel vasculitides, and this is important, neuropathy causing mononeuritis multiplex. Okay, this is a painful neuropathy. It involves a named nerve, and they're infarcted one at a time, so it's asymmetric and painful. And when a patient has this, you can see it with diabetes and trauma. Without that, it's a vasculitis. So like palpable purpura, mononeuritis multiplex is something that you could see with vasculitis, especially medium-sized or small vessel vasculitis. The large vasculitides, giant cell arteritis is the big one. That occurs in older people. Okay, and classically, you want to diagnose that as soon as possible because it could lead to blindness. You could get an arteritic ischemic optic neuropathy, and the patient could go blind. And you know, when a patient presents, an older patient presents with a headache, you have to think of this. However, there's a big subset of these patients now they're finding they have subcranial giant cell arteritis. So they have giant cell, they have large vessel, the aorta and its branches. Takayasu's you see in younger people. It's an inflammatory vasculitis also, but you see it in younger people. It can involve the subclavian, it can involve the renal artery, it can involve the aorta or its branches also. The other thing, IgG4 related diseases, these are a whole new spectrum of diseases that have been reported on in the last 10 to 15 years. They could cause autoimmune pancreatitis. They could involve a lot of different organs, but they could also involve the large vessels. And this is something to think of in a patient with a large vessel vasculitis, especially if they don't have giant cell arteritis. Behçet's disease we don't see as much, and classically involves eye involvement and pathergy and genital urinary involvement, but they could involve large vessel vasculitis also, and also with Behçet's syndrome, obviously aphthous ulcers. So let me just summarize my feelings with vasculitis. You have to understand what it is. It's inflammation of blood vessel with destroying the wall. Number two, you have to know when to recognize it. Think of the mnemonic spin. Then you need to categorize that, whether it's large, medium, small, or very small, or the appropriate diagnostic tests. And then obviously you need to treat it, which involves steroids or immunosuppressive agents. And usually you're going to work in conjunction with the rheumatologist to treat these people. And I'm going to sign off now in the trenches. Thank you.